Okay, in no particular order, we're going to introduce our next speaker, Dr. Althea Aquart Stewart, consultant pulmonologist, internal medicine specialist, interest and critical care at the University Hospital of the West Indies. She's an associate lecturer in the Department of Medicine at UWI, an undergraduate training at UWI, DM Internal Medicine also at UWI, fellowship in pulmonology and critical care, the University of Toronto, University Health Network. She's a graduate of, these are her words, not Campion, literally her words, Woolmer's Girls High School. And keeping up with the Child's Month, she attended Mavisville Prep School. All right. She's a principal investigator of the BOLD study in Jamaica locally. Please welcome Dr. Althea Aquart Stewart.
Good afternoon, everybody. I hope we don't have any ethnic fatigue. And I'd like to thank all of you for coming back to hear the second part of this conference. I'd like to thank Cari-Med, Miss Vivienne Walker, and Abbott, Kelly, for inviting me to participate in this conference. And I'd particularly like to congratulate Miss Walker for thinking outside the box. Who thinks of environmental impact and stress and workplace stresses and acknowledging the fact that these actually contribute to the chronic non-communicable diseases. So ladies, take a bow. Ms. Walker, excellent job. This section of the conference talks about in air quality, the environmental impact. My patients are largely affected by what they breathe. However, where the first part spoke a lot about stress issues, speak to my asthmatics and they'll tell you about the role of stress in their asthma exacerbations. Anyway, let's moving on. Air quality and environmental climate change, everything is big. So big that it was one of the features in the Annals of Internal Medicine in the May issue. And to quote directly from the journal, it says, poor air quality contributes to and is a consequence of global warming. The burning of fossil fuels to power our homes, those of you who haven't gone solar, businesses, automobiles, all the fancy new cars on the road, contributes to air pollution. When released into the atmosphere, some forms of pollution trap heat. You're talking about the greenhouse effect, which my learned colleague, Professor Taylor, will expound on. But air pollution, this greenhouse effect leads to temperature elevation, and we all experiencing it. We all know how hot and scorching the temperatures are. And air pollution has direct effects on health, such as worsening of cardiopulmonary disease. Now, Mark spoke about stress in his cardiology presentation, but what I found interesting in reading is even the inhalation of a large amount of particulate matter in the air in patients with coronary artery disease can lead to acute myocardial infarction and heart failure. Well, I know this is where we'd all prefer to be. This is a picture of the South Coast when we were doing our BOLD study. Nice clean air, beautiful scenery, nice countryside. Now, we're talking about air quality, so I'm going to use terms that GSAT students talk about, but this is just a reminder. We're talking about global warming. And what the hell does global warming mean? Global warming, which my learned colleague will expand on, but in my nutshell, it really is talking about the increase in the Earth's the temperature of the Earth's atmosphere over the last couple of years. And we can all testify to that. The melting of glaciers, etc. But what happens is that this increase in temperature comes because of these greenhouse gases, which trap heat in the Earth's atmosphere. And as a result of that, the Earth's temperatures become much higher. So what are these greenhouse gases? Well, we're talking about things like carbon dioxide, methane, the fluorocarbons, and the other pollutants. And when we talk about these things, just think about the number of new cars on the road. They are still gasoline driven, diesel. Think about all of the air conditioner, and most of us are not yet solar. All of these things, by increasing carbon dioxide, methane, are enhancing the greenhouse effect and making the place hotter. Then there's a big issue of air pollution. Who knows about air pollution? That's only a North American phenomenon. Not true. Not true. I think if you listen to the politicians as the presidential campaign goes on, everybody is talking about environmental protection, global warming, greenhouse effect. It's big. It means something. And when you get your next natural disaster, either a hurricane or some tornado, then you'll understand the significance. But whereas North America has these agencies that are set up to monitor the environment. For instance, the US has the US Environmental Protection Agency, which was actually established by President Nixon. We are not without our own body. And I'd like you to recognize the National Environmental Protection Agency does do a lot of work. It doesn't have the resources that the US Environmental Protection Agency will have. But within its resources, it does a lot of work in monitoring air quality. We're talking about working towards developing an air quality index. They're actually hoping to launch an air quality index in June, which is next week. Air quality, we're talking about, looks at particulates, volatile organic compounds, for example, benzene, sulfur dioxide, nitrogen dioxide, and what is emitted into the atmosphere. And I'd like you to take some reassurance that there are certain companies, Caribbean Cement Company, they actually do some air quality monitoring and particulate monitoring of the environment. So they have air quality equipment set up when I made my investigations by Maritime, by Harborview, by Rockfort Mineral Bath to assess the air quality with the emissions from their factories. So all is not lost. It's just not a North American phenomenon. We just need a little bit more resources to adequately invest. But we need to also recognize NEPA's limitations, lack of funds to measure dioxins and furans from the burning of plastics. Familiar? This is an emission from an industrial facility. I'm not sure. This is usually along the airport road. But this is much nicer. This is where we'd prefer to be breathing in the air in this particular countryside, not the industrial emissions. So I'm going to go into air pollution. Air pollution is the introduction of these particulates, biological molecules, and other harmful materials into the Earth's atmosphere. We spoke about the benzenes, the sulfur dioxide, the nitrogen oxide. We spoke about all the different chemicals from the burning of these plastics, etc. But these chemicals with continued exposure cause disease, death, and can also cause damage to other living organisms. Now, bushfires. We saw the industrial pollution, but we are also guilty of some of this pollution. These are the bushfires. Anybody who lives in Jacks Hill can tell you about the stress whenever those hills are ablaze, because you don't know how fast or how close the fire will encroach on your homes. Fire at a tire storage facility. People around breathing in this air. My asthmatics and chronic respiratory patients will never be able to survive. This is the same facility with the smoke being emitted into the air. So what we're going to look at the environmental impact on chest infections. Not only is it the particulate matter and the gases, but what we're breathing around us. Environmental impact on the development of chronic airway disease and worsening of the chronic airway disease in patients who already have respiratory problems. Occupational lung diseases, which we tend to sort of brush over a little bit, and what can we do to eliminate or to reduce the burden of these problems? Well, we spoke about air pollution. You saw the pictures of the industrial emissions. But whereas that was an industrial emission, you also have the problem of car emissions I have a patient who lives by Abbey Court, and she has bad lung disease because she's right across from all the traffic as it goes along Hope Road. Chemicals from factories, dust, pollen, mold, spores, which are suspended in the atmosphere, and what happens is that we inhale these things. So we are looking forward to the fact when we can have air quality monitoring, not just reported to us on a yearly basis, as is seen on the NEPA website, but that we can be actually warned what the air quality will be like so that our patients can protect themselves. Now, this is a Riverton fire, and you can see the smoke and smog that's surrounding the city. And that's the same thing. So my asthmatics, my chronic COPDers, they don't do well. When this situation happens, patients with chronic respiratory disease need to be advised limiting your outdoor activity, not going out if you don't have to go out. I know that implicates jobs, etc. But this is a situation when they go out, they're going to run into problems with breathing. We saw this as well before when we had some chlorine explosion and all the children were fainting and so on. The rapid inhalation of these fumes can be very irritating to the lungs. So what happens to these patients is that it will not necessarily cause asthma or cause COPD, but what we need to understand is that patients who already have it, have asthma, COPD, and chronic respiratory disease, their condition will be made worse, absolutely worse. And there is a thing where you can get a hypersensitivity reaction as a result of the acute inhalation of these fumes. As a result, what happens is it may be so bad these patients will need to go to the emergency room to be treated. But what an educated asthmatic who is aware of his disease or her disease will do is to know that I must step up my control of medication. This is a problem, a major problem, the open burning of garbage. We find it very acceptable culturally. This is fine if it's not done near to somebody's home. But unfortunately, this practice is done with the neighbor who is right beside them, who has a child who is asthmatic, or the neighbor, the adult themselves is asthmatic. And the person who is doing it really couldn't care less. And I think what we have to do is to consider improving our garbage collection so that this habit will not be done, because the people who do it are totally selfishly unaware sometimes of the impact they are having on the other people who are in their community. So we spoke about chronic airway disease, we spoke about the environmental pollution with particulate matter and gases that are released into the atmosphere with burning. But something that is still even more topical. Not only are my asthmatics and chronic respiratory patients affected by fumes and dust and pollen, but something that's very real is the relevance of chest infections that are in the air around me that I'm breathing. I was listening to a report the other day, something Andrew Hone, or Prime Minister Andrew Hone has said. One of the deadliest animals is a mosquito. But it's not the mosquito we're talking about now, we're talking about these viruses. Everybody remembers SARS, which went back in 2003. The SARS virus, which was a coronavirus. It was a major epidemic in 2003. And the principle for these viral infections, whether it's a SARS, whether it is H1N1, is that the secretions are, or there is aerosolization. It becomes a spray. Whether a cough, sneeze, sing, it is aerosolized and I inhale it. And what is frightening is that I will inhale it and I may not even have symptoms of the fact that I'm ill, but I'm releasing the virus in a droplet form, which you can inhale and you who will now become susceptible to infection. And this is real. We had SARS, remember when everybody was going around with masks on their face all over the world in 2003. But to come closer to home, H1N1. It came out in swine flu In 2009, it was huge. It was a pandemic. People were dropping down all over the world with H1N1 infection. And we thought, okay, wonderful, it's gone. But viruses don't go away. Just remember what happened to us between March and April of this year with the number of people who were affected by the H1N1 virus, and we actually had deaths. So what happens now is that you have a patient, especially the ones who have chronic diseases, who are exposed to these viruses. Their chronic diseases become worse, they deteriorate quickly, and they will end up in hospital in severe respiratory distress. This was people going around with masks when the landfill was on fire, and even during the time of the SARS epidemic where I had these masks. Please note the mask, because that is sometimes only protecting the brain, not the lungs. This chest X-ray is to show you what can actually happen with a simple viral infection because of the severity of the pneumonia that it can produce, especially in somebody who is elderly. But it's not just the elderly. Young people can be affected similarly. Look at that chest X-ray, because this is acute respiratory distress syndrome. Simple viral infection that has escalated and gone totally out of hand till the patient has progressed to ARDS. This patient was ventilated and intubated in the ICU. We're still on infections. We spoke about the deadly viruses. H1N1 is real, and I can guarantee you that this year, you are going to make sure that your clients, your patients, get their flu shots. It is real, and the vaccine does cover the H1N1 virus. So whatever the new influenza virus will be when the flu shot comes out. So anything we aerosolize still will cause problems because we're breathing it in. TB, ever present, ever living. Still a dynamic disease, worse with the onset and development of HIV. Huge. It's an old disease which still continues to wreak havoc. And the thing with TB now is that I will spray it to you, I will cough it to you, I will sing it out to you, and you will inhale it. And it goes directly into your lungs, into the distal alveoli, and start to set up house. The problem comes if your immune system is not up to scratch. If you are immunocompromised in any way, then we're going to have problems, because what in an immunocompetent patient will be taken, dealt with, and shut down. In the patient who is not immunocompetent, it's going to become fulminant disease. It's not so bad when it's simple, nice, easygoing, isoniazid sensitive TB. But we have gotten far more sophisticated with global travel. We now have TB that is resistant to the hallmark isoniazid and rifampicin. So we have the multi-drug resistant TB. We have TB that is extremely drug resistant, which is resistant to isoniazid, rifampicin, fluoroquinolone, and one of the injectables. And that is real. We sequester them at national chest and pray, because what we do have to use is very limited. This is a patient I had last year, and you can see the changes. Okay, I'm sorry. You can see. You can see the changes in the upper lobes. Classic reactivation TB, which was pretty bad, but thankfully his wasn't one of the resistant strains. He did well, and we're able to discharge him. So we spoke about pollution. We have looked at particulate matter, the gases, all those things that are there in the air that we breathe. Now I want to look at a pet peeve, secondhand smoke. Something that we are very casual, very carefree about. And one of the things, until legislation was introduced to try to reduce exposure to secondhand smoke, that people became far more aware. This is US data which talks about the impact of secondhand smoke, and it talks about it affecting about 58 million non-smokers in the USA, including 15 million children. More than 7,300 cancer deaths. I don't smoke any cigarette, I don't do nothing, so why am I getting lung cancer? And I know that you know somebody or have had somebody who has never smoked a cigarette in life, but they end up with primary lung cancer. They can also cause more than 34,000 deaths from coronary artery disease. Their patients have a 20% to 30% increased risk for stroke. And of course, there is always a problem of increased adult onset asthma. They have never smoked, but these are the risks that they run. This X-ray you should be familiar with. This is the classic COPD X-ray with the hyperinflated lungs and the thin heart. But thankfully, he's only hyperinflated and short of breath, but it doesn't show anything to suggest any malignancy. Okay, Now, we spoke about the number of adults, but what about the effect on children? Because anecdotally, when the legislation was introduced about reducing smoking in public spaces, the number of children who are actually seen at Bustamante Hospital for acute episodes of wheezing, it decreased. In children, they are more prone exposure to secondhand smoke, more likely to have asthma. And if they were already wheezy, you can guarantee it's going to exacerbate. They have an increased incidence of respiratory infections. They will get reduced lung function. They will get chronic otitis media. They have a higher incidence, a higher risk for sudden infant death syndrome. And of course, if the mother is stupid enough to be pregnant and smoke, then there is always low birth weight baby and premature birth. So secondhand smoke is not to be taken lightly. Now, the people who smoke will tell you that there is nothing nicer than nicotine. It is the greatest thing. It makes me feel wonderful. When that nicotine goes and releases dopamine in my brain, the world is a wonderful place. But the problem you face is that the cigarette smoke has a gaseous phase and a particulate phase. But it's not just the joys of that nicotine and dopamine release, but I'm also getting nitrosamines, benzopyrenes, and polycyclic hydrocarbons, which are carcinogenic. Remember, we're talking about you don't smoke, but you're inhaling this from whether it be your boyfriend, your husband, or whoever you are continuing to inhale this from. And unfortunately, I see this far too often. You present to us at this stage with a complete whiteout of the left lung. There is fluid there. There is, in addition to fluid, there is a tumor there. This is advanced lung cancer. So we have looked at infections. When I aerosolize it and you inhale it. We have looked at the particulate matter, the pollutions. We have looked at chronic airway diseases. We have looked at the infections. What about at the workplace? This is real. Now, we all have stress at the workplace. We all feel it, but I'm talking about what about the air that we're breathing in our working environment. This particular group of diseases called the pneumoconioses are diseases that develop. It's a group of interstitial lung diseases caused by the inhalation of inorganic dusts. Now, these dusts, right, you are in the environment, you're earning a living, you're enjoying it, you're able to put food on the table, pay the rent, etc. But after chronic exposure, we're talking about 20 years, it doesn't develop right away. It develops years later, 20 years and more. What happens if those inhaled particles are of the right size? It goes into the distal airways. Notice I keep on talking about the right size. And I keep on saying that the mask was protecting the brain more than the lungs. There's a reason for that. When it gets into the airways, now it sets up this inflammatory reaction. And that inflammatory reaction goes on. Lots of cytokines and everything, the inflammatory reaction continues. Even sometimes when you leave the work and you change jobs, that inflammatory insult is there. And what happens is that it can eventually lead to chronic lung disease with scarring and fibrosis. Can I add a little footnote here? This tends to be worse in my employees who are smokers. The risk is greater in these people. And this is a CT scan to show what happens years later. They come, they get shortness of breath, they can't breathe, little bit of exertion, it's not cardiac, it's all respiratory. And you start to take a more detailed history to find out what they did, where they were working, what sort of exposure they had for how long. Then you would do the CT scan and you will see all of that scarring. That's where you see the patient comes in short of breath. When you see here, this is all the scarring of the lung, and these are airways which are dilated. These are airways here which are inflamed, not yet fully scarred. They are salvageable. But over here is scarred lung, where you're getting dilation of the airways because of the underlying fibrosis. We call that traction bronchiectasis. So you have that picture with a history of smoke, with a history of shortness of breath, difficulty breathing, and you dig deeper and you realize that they worked at some plant, whatever, and they were chronically exposed for many years. Another one that we can't afford to forget is asbestos. Asbestos is alive. It is a problem. And unfortunately, asbestos doesn't just produce the fibrosis that we saw on your previous scan, but asbestos is notorious for creating lung cancer, whether it be a primary bronchogenic or a mesothelioma, both of which are bad news. Now, in terms of the dust, we see it with patients who are regularly exposed to beryllium in the making of fluorescent light bulbs, people who are doing coal mining. Now I pause here because we don't really have coal mines, but what we do is burn a lot of coal and expose a lot of the dust and fumes. The silica and aluminium, those industries are notorious for the organic dust that their employees will inhale. Lastly, pesticides. Pesticides. I've seen this with the coffee people who spray the coffee plants, and those young men are tremendous users of grabber, tobacco and marijuana. And what happens is that they refuse to use the masks that they will get, that they have been given to wear. So pesticides and the continued inhalation can be a potential problem for patients who are continually exposed. And as I keep on reminding you, the effect of these exposures are heightened in smokers. So, in conclusion, in reviewing the environmental impact on lung diseases, what's my take home? What can I do to minimize or to reduce this? There is no doubt, absolutely no doubt, that poor air quality affects respiratory health, and it will aggravate existing disease in people who are already challenged. So, avoid exposure where possible. We also need to educate our employees about appropriate protective masks. And I remind you that the little dust mask is not going to keep out particles that are smaller than a certain size. You're protecting your brain, you're not protecting the lungs. So it is important that people wear the correct masks. And even us in our everyday work, if we know that we are vulnerable and exposed, we wear remember the problem, is the aerosolizing. When the patient sprays it, coughs it, sneezes it, that's when I'm going to inhale it and run the risk of infection. There should actually be penalties for employees, especially in industry, who do not wear the appropriate masks. They must be provided, and we should ensure that they wear them. There should also be the yearly testing of employees to evaluate for complications of pesticide exposure, complications of chronic inorganic dust exposure. And yearly evaluations must include a chest x-ray so that you can compare the developments this year with what the chest x-ray looked like last year. If a chest x-ray is not good enough, move on to a chest CT scan. You need to have that, In addition, you send them to a specialist to assess pulmonary function, because I need to know, is my patient's lung capacity being impaired by the continued exposure, what they are inhaling. And please, whether you are seeing them as a patient at a pharmacy, or you are seeing a colleague or a husband or a friend, use every opportunity to educate about smoking cessation. Because these inorganic dust, I repeat, the effect is worse in the chronic smoker. And finally, something that I think will be much easier this year, encourage the yearly flu shots among staff, hospital staff, work staff, your colleagues, who, especially those who already have the diabetes, the hypertension, the renal failure, the sickle cell, the asthma. It is important. Remember that slide with what was a simple viral infection, how it went on to ARDS? That's real. I didn't take it out of the internet. Encourage the flu shots in the elderly, and encourage your flu shots in your asthmatics. They have a different philosophy when it comes on to management of their asthma, and it will get worse. ICU space is limited. We can't offer ICU care to everybody. At this point, I'm to stop. Okay, I just want to say special thanks to a lady I met at NEPA, Miss Jody Ann Marston, who explained to me about the NEPA's monitoring, and she provided the pics on air pollution. I'd also like to refer you to the NEPA website. Unfortunately, they tell us about air quality in the previous year. They are hoping, as I said in June, to establish the air quality index. This is spirometry. This was a part of the BOLD study to look at lung function, getting the patient to take a deep, 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 deep breath and blow as hard, as fast, and as long as you can. It requires a lot of neurons to do. You have to think about what you're doing. And isn't this nicer? This is much, much nicer. This is what we'd like to breathe every day. Thank you so much.
Okay, so thank you very much. Let's hear it for Dr. Aquart again. Stewart. Boy, my technical team will work with me. Pop, 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 pop. All right, so we're going to take 3 questions, and Doctor will answer those. All right, so go ahead.
Really an interesting presentation and very timely. I have a great concern with what I'm seeing now with the spraying of the mosquitoes with the Zika virus. I noticed that the pickups just travel through the community, and whether you're walking or whatever, it just sprays a cloud of pesticides on the persons. And most concerned about that, number 1. And number 2, the workers themselves, I don't think they're adequately protected. And at the point of being accused of, I don't think the Ministry of Health is really exercising the way it should in protecting persons adequately. Let's like to comment on the fact of that spray, the supposed great spray to prevent.
Thank you very much for the question. You're caught between a rock and a hard place. We have to get rid of the mosquitoes. We have to destroy the breeding sites. We have a responsibility to try and do something. Now, there is data. I don't have access to that data that's supposed to tell you how really effective is the spraying in eradicating the mosquito, if it is really as effective as we think it is. What can we do in that situation? Twofold. The persons who are doing the fogging need to be wearing appropriate masks, and they should be rotated. He can't be fogging alone. He needs to rotate, and he does it twice per week, whatever, so that he is not overexposed to pesticides. For those of us who are in our homes who smell the spray, the only thing that you can advise is that they either wear a mask, you can use a damp cloth, put it across your your nose and mouth, but stay indoors. And I know you're going to tell me that even if you stay indoors and locked, you still have the residual smell. I absolutely agree. The only thing is that the smell is not as intense as if you had everywhere open. So we need to make sure that the ministry is aware of the risks to the patient, to the people who are fogging, and we also need to be aware an asthmatic could have an asthma attack triggered, and COPD could get acute shortness. Mm-hmm. Yeah, that is a little untidy. It is untidy. The only thing if you're actually caught outside your home is to find something to cover your mouth and nose. But that in itself is hard. But in this day and age, we should be able to have a proper schedule and know and reduce the risk to the population. I agree. Thank you.
Okay, based on the length of that question, we're going to take just one more. Someone from this side now?
Somebody should go into the mic.
Oh. Hi, Dr. Aquart Stewart. I think it would be a lot to not answer this question. This time of the year, where there's a lot of patients that come to us regarding dry coughs and sore throats, both in adults and children. In your opinion, what would you consider the best over-the-counter treatment for such conditions?
That's a difficult question. Anybody who, and it's a real question, because first thing you need to establish is how long has the patient been having the dry cough. Dry cough can be a sign of chronic lung disease. So they need to see their practitioners to make sure there is nothing else there that is causing the dry cough. Dry cough could also be a side effect of one of the most famous classes of drugs, the ACE inhibitor, right? Dry cough could be just due to something viral. Dry cough could be asthma. Could be early onset asthma cough variant. Dry cough could be due to chronic sinus drainage. There are so many things. So to say, well, what is the best over the counter? I'm hesitant. Until you can establish from that patient how long this cough has been there, it means you're going to have to find out, take a history, what drugs. I'm cautious. Let them see their practitioner, and then you can you can have it clarified as to what is causing it. If you establish that it's a simple sinusitis, rhinitis, postnasal drip, then give them an antihistamine. But it means you have to spend the time to ensure that rather than prescribing and you are missing something else that's going on. Is that clear?
At this point, we're going to have Ms. Carol Marshall to make the presentation.
Thank you for a very, very interesting presentation. Very insightful, most interesting, very thought-provoking. So on behalf of Cari-Med, in partnership with Abbott, I'd like to present this token to you. Please accept it, and thank you again very much.